Assalamu alaikum. I am Dr. Nazmul, endocrinologist, Evercare Hospital, Dhaka. Today, I am going to discuss certain questions that has been arised by our surgical team, and this is frequently asked by many surgeons in any hospital. In short, first of all, the question is, what is diabetes? Diabetes is a group of metabolic disorder in which there is high blood sugar level and derangement of protein, carbohydrate and fat metabolism. The second question is, what are the types of diabetes? Actually, this is a lengthy question, but for all practical purpose, because this talk is only about hospital management, there are two types of diabetes, type 1 and type 2. Type 1 diabetes means where insulin is essential for survival and death may ensue if there is no insulin. Whereas in type 2 diabetes, usually these patients are above 30 years old and they don't at least initially require insulin. But there are certain overlaps in these two. These are not strictly different conditions. Now, clinical findings. In the beginning, in type 2 diabetes, we are discussing type 2 more because these are majority of our patients. There may not be any symptoms at all. The classic symptoms of frequent micturition, excessive appetite and excessive drinking of water, they only happen when the blood sugar crosses certain threshold. Now, these are difficulty in vision because your eyeball increases and decreases in diameter. There may be atypical infections, for example, excessive Crohn's and acne becoming infected. There may be urinary tract infection in ladies, and even there may be genital area infection. And in extreme condition, for example, in acidosis, patient may develop vomiting and even coma. Now, lab parameter wise, there are international guidelines regarding diagnosis of diabetes. Fasting blood glucose of 7 millimoles or more, and after meal blood glucose of 11.1 millimoles or more, or HbA1c level of 6.5% or more would constitute diabetes mellitus. These days, glucose tolerance test is rarely used because of inconvenience to the patient. They are not recommended anymore. In terms of preferred investigation, this is actually a very broad question. So, I am only talking about general investigation because investigations will depend on the patient's condition. First of all, we would definitely do a blood sugar level, preferably fasting and 2 hours, and HbA1c should be drawn. And kidney function is very important, creatinine, and in selected cases you might need to do urine for ketones. In short, the next question was the role of diet, therapy and exercise. The diet is usually about 18 to 20 kilocalorie per kg of ideal body weight, and they are divided into carbohydrates, protein and fat. Carbohydrates should be about 50 to 60% of the calorie. The rest too is almost equally divided into protein and fat. Fat should be in monounsaturated form. Exercise recommended, the minimal one is 30 minutes a day, 5 times a week. Aerobic exercise has been encouraged lately by American Diabetic Association because they have certain benefits, and also strength exercise. Preoperative precautions and measurements to be taken. Now, diabetic patients, if these are elective surgery, they should be admitted at least 1 day before your surgery. Especially if it is a major surgery criteria is more than 2 hours under anesthesia. And it's better to control the sugar and if necessary inform the diabetologist before actual day of anesthesia. And we again check the blood sugar parameters, kidney function, creatinine and urine as a minimal investigation. In terms of control of blood glucose, if the patient is on diet alone, no specific treatment is necessary other than diet. In type 2 diabetics who are on single medication, especially like DPP-4 inhibitor, you can continue the medicine before the day of surgery. Metformin should be stopped preferably 24 to 48 hours before surgery. And sulfonylurea must be stopped at least on the day of surgery. Insulin can continue, and in type 1 diabetes they must continue. In type 2 diabetes the basal insulin should be given the night before surgery, and it should be at least 60% of what the patient takes. So in surgical list, the diabetic patient should be first in the list because they have much higher risk of complication and death. So first patient should be in the list is diabetics unless there is no other way. In terms of diabetic control, the standard practice is to infuse 5% DNase, in which you should add 10 units of acrapid. But remember, in our country, people have high degree of insulin resistance. So in my experience, 10 units of acrapid is almost never enough. I tend to use 14 to 18 units depending on the BMI of the patient. And it is important to check potassium before starting the infusion, or definitely within 2 to 3 hours. As you know, that potassium goes inside the cell once you start glucose and insulin infusion. Blood sugar should be measured at least 4 to 6 hourly. If the sugar is high, then you should measure it 2 hourly. And potassium should be added in your drip if the potassium level is less than 4 millimolars. Which IV fluid is suitable during surgery? As I said, we tend to use 5% dextrose in normal saline and add insulin into it. You can use separate infusions for insulin pump, in which it's much more easier to control blood sugar level. Routes of delivery of insulin in post-operative patient if the patient is NPO. Well, the patient is not in shock, has good circulation, you can use subcutaneous insulin, no harm. But if the patient is critically ill, the best route is intravenous route, because you can adjust the insulin levels and your blood glucose frequently. How frequently to check the blood sugar? That depends on the clinical condition of the patient. If the patient is very ill, you might need to check even 2 hourly. If the patient is otherwise stable, 4 to 6 hourly would be a reasonable number. When to restart hypoglycemic agents? Here some clinical thoughts come into play. If you believe that the patient is well enough, start it on medication, and you are unlikely to go back to NPO again, then best thing is to start slowly oral anti-diabetic medications. The new anti-diabetic medication, SGLT2 inhibitor, like empagliflozin, dapagliflozin, they should be restarted with caution, because as you know, they causes dehydration. So in that case, diabetologist opinion is better sought. Now in terms of diabetic ketoacidosis, this is more common in type 1 diabetes, but I have seen this happening in type 2 diabetics as well. First thing is to be aware of such a thing, and these patients tend to be ill for at least 2 to 3 days with increased urination, feeling ill, feeling feverish and frequent breathing because of acidosis. They tend to have fruit-like flavor in their breathing, but it's sometimes difficult to understand for everybody. The lab-wise, the blood sugar level is usually more than 250 milligram percentage. The blood gas should be done, and the pH is usually less than 7.3, and bicarbonate would be less than 18 millimoles per liter. And urine is positive for ketone. And investigation wise, you should do serum electrolyte, frequent blood sugar measurement, and when possible blood gas measurement, because we need to change the fluid therapy frequently based on those parameters. Thank you.